Thank you. I was asked to come back after last year. I went through an enlightening, magical experience of going on my own after being in many, many different practices. So basically, I just wanted to let the audience know that I actually trained here in Orlando, so I did my residency in Orlando. I was a chief resident and graduated in '93, and then went to Fort Myers, and have gone through many gyrations of practice, and now have my own, I'm restarting my own solo practice as of last year. One of the things I wanted to do, one of my goals was to kind of, I guess, disclose our professional culpability in the dilemma and problem that we have. The culpability is tacit, and I believe inherited. In other words, I've been in practice, I'm 52, going on 53 years of age, and when I walked into practice and took a salary with some doctors, there were two options: Medicare, non-Medicare. And that was really it. It wasn't private or whatever, it was just Medicare, non-Medicare. And at that time, we could still balance bill. In other words, we could charge more than Medicare perhaps allowed. And then that went away in '97. So as I went along, I started saying, well, why does this work this way? You know, is this really consumer friendly? You know, I'm a buyer. Does this make a lot of sense? And it honestly just didn't, and it just kept in the back of my mind bugging me. And so one of the things I talk about a lot is the myth. You know, the myth that health insurance equals health care. We're propagating that myth by participating in contracts. And I guess that's what this is all about, is, you know, a contract needs to be mutually beneficial for all parties involved to be meaningful. And we're being harmed, and now our patients are really being harmed. They're being harmed financially, they're being harmed for access. And our continued insistence to dummy rubber stamp every contract that comes across the desk, I'm challenging anybody in the audience and all physicians in the country to rethink that position. And by the way, the power of stopping that changes the conversation on a political level, on every aspect. And all it takes is for us to just say, you know what, nah, come back and talk to me some other time. Right now, I've got my fees posted, and they're working fine for me. That's my challenge to everybody in the audience. So this slide is just to remind me how kind of mixed up things are. You got your third party, you got the patient, you got the doctor. And by the way, the doctor could be replaced by the hospital, it could be replaced by the surgical center. It isn't just us, you know, and nursing staff, nursing services, home health, whatever. But the point is, there's a big dollar sign that goes to that third party, who, by the way, make their money on the margin, which means if the money gets bigger, they make more money. So they're not really interested in saving the patient money, okay? Only you are, and the patient. So then we go to how that money gets spread around. Well, you got to pay the shareholders who started the capital for the insurance company. The insurance company's got to make all these claims, and it's very inefficient. So now I just want to move quickly. So I showed everybody last year my practice model. It's changed just a little bit. So what I wanted to announce was, you know, I kind of have, I'm not stuck on one model. I guess I am an entrepreneur. I'm trying to see what kind of works and what makes sense. And what I see is, you know, everybody's got different needs and desires. And I'm trying to accommodate that as long as it's reasonable and prudent for me. And so, for instance, you can come join my practice for just a meet and greet for $180. Now you actually have a doctor. So if you do get sick, you don't have to go to the ER or the urgent center. You can call me. You've established, you can come see me as needed. And that's just to get the young people, who, by the way, decided not to buy the Obamacare. Now they can come see me for $180 or $150 and we're done. And then if you need me later, it's fee for service. So I do like the direct patient care idea. It makes a lot of sense. And so now I've started doing that. I started offering memberships. And I'll show you in my marketing strategy what I did to enhance my membership enrollment was I provided patients with monitors as part of their being in my practice, and then that allows us another point of contact. So on the compliance issue. Here's my inpatient advocate service. I talked about that in length last time, so I won't bore you too much, but the point is, I've created a product that is specific, and it's only for your patient. So in other words, it's not a network to start doing more work for other doctors. It's for you. But what it does is it gets you a value proposition to your patient, and if you're willing to do the work, which is to come and advocate, meaning come and see them at the hospital, you don't have to be the attending. You simply have to have access and be able to be helpful, and that means you need to be able to have privileges, at least on a courtesy basis, so that you can read the record and see what's going on. And you're there basically to just help that patient in and out of that transition to make sure that they get properly managed and cared for. It turns out to be an extremely powerful product, and it's something the market wants. The doctors, I'm on a Facebook post, thanks to Dr. Rebecca. Where is she? I saw her, there you are. I'm on their DPC chain, and I'm trying to, what I see a lot is they're very reluctant. Right now, the family medicine doctors in particular, and I'm an internist, so I spent almost all my training in the hospital, so I'm more comfortable in the hospital. But the DPC doctors are, in my view, they're missing an opportunity if they would offer themselves to be at the hospital. And that's not really in there. I'm not seeing that in the conversation, so I'm slowly, Rebecca, tweaking that in there. So anyway, what I did is I created 3 different members. Actually, I have two kind of membership options. I got this one option that's unlimited access to the Inpatient Advocate Service, and I got one where the Inpatient Advocate Service is an added service that you have as a member, but I charge by the hour, and I charge $3.75 an hour for my services. And so, as you can see, there's different price points, and what I find is the gold membership sells like hotcakes. I got all these people that have been not allowed, they haven't been underwritten, or it's too expensive to be in the insurance pool. So I've got these 50 to 65-year-olds who have their own businesses, they've got cash, they got money, and they're just trying to get to the doctor. And some of our practices in town literally will not work with people for cash, which is amazing. I wonder what they'd do if they came with gold. One of the things I wanted to do, I'd take it, by the way. So I wanted to, one of the things that always worried me when I did this was what's going to happen, who's going to stay, what's my retainment rate going to be? So I've got the numbers for you guys. Here it is. 2016 memberships not renewed. 48 total. I'll give you the total numbers in a moment. It's a little fudgy. There's 5 that says other and 11 various reasons. They should all be together. There are 16 patients who left for uncertain reasons. 14 of my clients died, and they were all quite old, except for one young man who had a terrible problem, terrible end-stage liver disease. He was referred to Gainesville. I advocated fiercely for him, and unfortunately, he did not survive. 2 were expelled. 2 were bad people. I had to let them go. Well, I shouldn't say that. They violated the rules, and so I had to let them go. And then 3 of my individuals, I've let off the membership requirement because I know that they're experiencing financial hardship. One's a couple who are quite old, and they're out of money, and I know that. Very proud people, and I figured it out. So I told them, you come here and don't worry about that. 13 moved. People are migrating back to their families as they get older. That's what I see there. Here I just wanted to show, I could have shown in numbers, but last time I thought, that's kind of weird. People have different overheads, so I have kind of a higher revenue probably type practice, but my overhead's higher too because I do a lot of service. So I have LPNs, we do IM injections, I do joint injection, we do all kinds of things and I pay talented staff to be there, and I pay them a lot, so I pay them above market, I should say. Now, so what I want to show you here is I didn't get harmed this last year in transition, and by the way, one of the reasons my revenues are down this year alludes to your issue. The group that I left, we did not meet meaningful use in 2014, so this last year I got deducted 2% all year for the things that happened in 2014, and it added up to a few bucks. So that affected there, but the good news is I cut my overhead some more. So as you can see, I pretty much netted, and when I call net, I say salary plus retained earnings for future operations, about the same amount of capital. Facts and figures. Number of memberships by year. So again, my first year was 366 members. I netted 410. So despite the fact that I lost 46, I netted another 60-some. So we got 90 new clients, which if you go back to my old talk, I predicted I would get 90 new clients. That's pretty accurate. I'm sure it was a pure accident. But anyway, that's being optimistic. See, if you just think about it, the future will come to you. Next, I just wanted to show what happened. You were talking about the fact that you got to get less dependent on the system. That was an intention that I had as well, and I'm pleased to report it's happening. Not that I'm pleased that I have less Medicare patients per se, but I got to tell you, it's refreshing to me to not see everybody 65 and over. I get to see these younger clients, and it's wonderful. Hey, you're not so sick, and you don't have so many problems, and you're not so slow, that I got to watch you walk, through the hall and all that stuff. I love these people, don't get me wrong, but it's energy consuming to be doing that all day long. Being a geriatrician is very, very difficult. The neurologist is not. Pricing, this is the other thing. I wanted to give you guys some meat, okay? So how to decide fees. Now, in my case, I have an established practice, so I have data. Now, this is where computers help you, and sometimes codes help you. And yes, often they're fraudulent because we're being asked, by the way, MACRA is going to ask everybody to make everybody as sick as possible in order for you to get your bonus. So by the way, the data that comes forward from our national database, as long as MACRA is in place, is even going to be more questionable. And it does have national impact because that data is going to get used in the media to tell the world what a terrible place America is for healthcare. And the truth is, it's going to be completely fictitious. It's going to be wrong. Back to the story. All right, so I say, look at your prior year visits. See what you got paid for that, contracted or otherwise, Medicare or otherwise. Divide the revenue by those visits. That gives you what you're being paid per interaction. And it doesn't divide it by level of complexity. That's just how much work you did and what you got paid. Now you have to go and break down your expenses. And that requires that you do a spreadsheet and actually see what all your cost is. How much do your employees cost? What's the tax on that? What benefits are you providing? All that business. Get that down into a working hour overhead hourly cost. So if you're working in your office for 36 hours, or your office is open for 40 hours, take all that stuff, divide it by the hours, that's your hourly rate of revenue you must generate just to pay the overhead. By the way, it's an astounding figure for me. It's like, wow, these $80 visits aren't going to work because I actually need more than that. So, and then if so, then look to see why. But these are the facts. This is just being objective. So that hourly overhead cost minus my salary gives me that hourly revenue break-even figure. Next, you go and determine your personal financial objectives. What do you want? What do you expect? What do you need? And this then will give you, you'll have to decide your wages, your benefits, and what is your retirement plan? How are you going to put your money, how much are you going to save? How much are you going to be able to, you got to put this into the cake. Otherwise, you're not going to price this properly. If you don't price this right, you will not be successful. You'll either be bankrupt or you'll sell yourself to an entity that's going to consume your life. So then you set your pricing from that model. Determine the percent added charge needed, and then take some targets and assume either the same level of work, or if you're going to assume less work, you need to make your assumptions. I did that, and I was fairly close to my assumptions. I assumed a certain amount of people would leave when I put this membership issue into play, and so you do have to take at some point a guess, but you certainly should know your hourly expenses. That's something you've got to know. And that's what I did for memberships. Is I looked, well, what are those non-Medicare people generating in revenue? And how many visits did I average? And what I did was, I upped my pay. And I said, this is what it's going to be now. But what am I giving you for it? That's the value proposition. And that's going to be different by each different doctor and each different specialty. I wanted to now move into competition because we are starting to see that. We're starting to see the direct patient care model. This Sergio thing is fascinating. I love it. Awesome. Can't wait for more. So my challenge to all of us is, what's going to be the value proposition? What are your credentials? What are your qualifications? What will patients get if they use a membership fee process or a package? And that's what I do. I sell packages too. If you see on my website, you'll see all these options. My inpatient advocate service turns out, in my view, to be a massive competitive edge. People really want this. I'm getting hired now. People are starting to call my office from the hospital. I just had a horrible experience and I heard you do this. Can I come join your practice? Sure. And guess what we do? We get them stable, medically managed, and it works for me and it works for them. Remote monitoring, this is what I wanted to share with you guys. I'm doing a beta project with this company, iRemedy Supply, and I'm a small investor in this company. And they do a lot of things. They're an e-retail operation, but the thing that really gravitates for me is they have a monitoring dashboard that when my patients enroll through me, their device, in this case it's a Withings unit or it's a Fitbit, weight scale, blood pressure, and these activity devices for now, and there'll be more in the future, we're able now to have another point of contact. So again, an anecdotal case would be a lady who came to me, joined my membership. She kind of knew she was unwell, and she came in, and she had hypertension. We let her try to manage it. She didn't want to take medicine, so I put her on one of these units, and we monitored her, and she took my behavior modification advice to heart, and lo and behold, over a 5-week period, she was able to bring her blood pressure down without me having to give her any drugs. So I find that very powerful. Next, we talked about the cash dispensing of meds. I just rolled this project out literally this week. I have not yet dispensed a prescription, but I have it all in place. And I did an email to my clients, I did a survey, and I got about 47 people who immediately said, yes, I want to do this. And then I just left this up for questions and answers. I'll move to the bonus slide, though, first. So the doctor's report. I didn't put this one on my bonus, but I did an article, I did a blog post called Macra is Not Smart. And I would love for all of you to get on that and read that one, because that's a blast. And that's all I need to say about that. Yes, Medicare's insolvent. That was the other article I had done. Then bonus 2 was need data if I'm going to plan out opted Medicare. So this was a note I made to myself earlier before the election. Now that the election happened, I'm not sure if I have to opt out yet, because I don't know what they're going to do. Maybe we're going to be able to work with this program and get people where, like we've talked about, saying I can contractually opt out and Medicare's going to, I agree, I'll take whatever Medicare's going to pay, but Coordinate or whoever can charge me whatever they're going to charge me. So what do you need to know? You need your total office visits for the last rolling 12 months. I need my active patient list. I need my active Medicare list. I need my 12-month rolling expenses report with and without the physician's salary, average per visit fee collected minus vaccines and injections, because under Medicare, a lot of vaccines are covered. So you got to roll that into there if you're going to go to these Medicare clients and offer them primary care services. I got to know that stuff. Average hourly costs for the current office, I already stated that before. I got to check my membership status and review it. I got to look at my membership revenues by type, and then ancillary revenues and costs. Earlier, I'm sorry, I showed my memberships. I think there was a slide there that showed you graphically which memberships are, how many people are in them. So that stuff's on a slide. Thank you.